Very good afternoon to all of you. We welcome you all for the second session on investigations and imaging in uveitis. This is our 1 hour session. So in this, the keynote talk, that is laboratory investigations, how to follow a tailored approach, will be given by Dr. Amita. Over to Dr. Amita.
Good afternoon. I thank the scientific committee for this opportunity and my mentor, Dr. JB, for his constant encouragement and guidance. I have no financial interests in my presentation. Now, the advanced diagnostic modalities have not really been able to elbow out our clinical acumen, so it's the man behind the machine which still holds relevance. So why would you investigate a case of uveitis? So basically to differentiate between autoimmune and infectious uveitis, to identify specific uveitic entities, and for diagnosis, prognosis, and for mapping our management. But that wouldn't mean that you go for a fishing expedition. I think between a totally empirical approach and a totally lab-dependent approach, a selective, thoughtful approach with tailored lab investigation is the best bet. There are certain uveitic entities where you would not need to order any tests, like a Fuchs heterochromic iridocyclitis, a traumatic uveitis, or an unequivocal case of VKH and SO, excepting that there would be some tests required for all uveitic patients whom you want to put them on oral medication because of their potential side effects. So before we think about investigating a patient, we follow a certain algorithm, and which will be in the form of a detailed history, a complete eye examination, try and identify the anatomic location and extent of the primary uveitis, and do an overall systemic evaluation. So with this, we would try and compare the clinical characteristics with known uveitic entities, try and come to a working clinical diagnosis, make your DDs, and order only relevant lab investigations first. You would need extensive investigations if there is a diagnostic dilemma or if the patient is not responding to your treatment. So we'll see a few examples. So this was a young male with an angry-looking eye, a hypopion. So we know it's an acute unilateral non-granulomatous anterior uveitis. That is what our working clinical diagnosis would be. So how would we approach this case? I think history would be very important. We would try and figure out whether it's the first episode or the patient has recurrences. And if he has had recurrences, what has been the response to previous treatment? In case of an absence of a history of oral or genital ulceration and a history of low backache, I think to start with, the only investigation which would be required is an HLA-B27. Another young male with mutton fat keratic precipitates, so working clinical diagnosis of a granulomatous anterior uveitis. So there are two etiologies which we would want to focus on, and that would be TB and sarcoid to start with. So we would rivet our attention to ruling out TB and sarcoid, which would be in the form of a Manto test, a quantiferon TB Gold test, serum ACE, and imaging where HRCT would be beneficial. In some cases, when there's a diagnostic dilemma, you might need to resort to an anterior chamber tap and do a PCR. Now, another patient with pigmented keratic precipitates, a steamy cornea, raised intraocular pressure, obviously the first differential diagnosis which should come to our mind is a viral anterior uveitis. And how would you approach this? I think we would need to do an AC tap and do a PCR to the viruses and try and figure out as to what is the etiology. This patient tested positive for HSV1. Now, a 25-year-old female with history of defective vision and floaters, and on slit lamp, we see these vitreous cells. And once we dilate, we see these vitreous snowballs. So obviously, it's an intermediate uveitis. So there's a whole gamut of etiologies for intermediate uveitis, but would we be doing all of them? Obviously not. Again, TB, sarcoid, these will be the two conditions which we would focus our attention on. In case there's a diagnostic dilemma, we might have to do an AC or a WIT tap and send the sample for a PCR. Now, HRCT for this patient showed miliary lesions and had tested positive for MTB. Now, when we see a retinitis, it is almost always infective. So when we are dealing with a case of retinitis, we would obviously not be thinking about autoimmune causes first, but we would want to rule out infections. For example, this patient, a 34-year-old male who came with complaints of decreased vision and floaters. So with this necrotizing retinitis and with scalloped margins, we know we are dealing with an acute retinal necrosis. So what would you do? Obviously, we would do a PCR for the viruses, and also assess his immune status, so do a CD4 count and an ELISA HIV. He tested positive for VZV. A 48-year-old male with defective vision and a history of fever. So this is where history is important. And we again see this patient with retinal exudates and hemorrhages. So we are probably dealing with a post-fever retinitis, so we would be thinking about a dengue, chikungunya, do blood tests, ELISA, and PCR. And this patient had 9 copies of chikungunya virus on a real-time PCR, was treated, and all those exudates just melted away. Now, this is a clinical diagnosis. I think all of us would be able to make it. A 40-year-old man with no history of contact with pets and a vision of 6/12 and 18. We see this lesion with an arteriolitis. We know that we are pretty much sure that we are dealing with a toxoplasma retinochoroiditis. But we would do an ELISA toxoplasma, IgG and IgM, and we would restrict ourselves from doing a PCR, which should be only for atypical cases. But this patient, he tested negative for a serum ELISA. We did an anterior chamber tap where he tested negative for PCR, but he tested positive for IgG on an anterior chamber tap. So ELISA toxoplasma has got a good sensitivity, and it should be done. So this patient was treated with antitoxo and oral steroids, and the lesions resolved. Now, this was an immunodeficient patient with diffuse multifocal retinitis. This was a diagnostic dilemma. He underwent a WIT tap, and he tested positive for PCR. Now, where else would you do an ELISA HIV? Any necrotizing retinitis or an HIV retinopathy, you must subject the patient to an ELISA HIV after appropriate counseling and consent. This was a 34-year-old male with defective vision. So this was a pan-uveitis, and you can see a hyperemic disc with vitreous involvement, placoid lesions. I think with this kind of a picture, the first thing which should come to your mind is an ocular syphilis. Syphilis is a big mimicker. So he tested positive for both VDRL and TPHA. So when we are thinking about ocular syphilis, we should do a treponemal test like an FTA-ABS or a TPHA, or a non-treponemal test like a VDRL or an RPR. For retinal vasculitis, again, the involvement could either be arteriolar or venular. So we know that all the systemic vasculitides and the viral retinitis can cause arteriolitis, whereas TB, sarcoid, Behçet's, pars planitis, they will involve the venules, so it causes a phlebitis. So would we be doing all these tests? No. So let's see a few examples. So this is a retinal vasculitis where we see that the venules are involved. There's a neovascularization. Again, in our part of the world, we'll be thinking about TB, sarcoid. So he tested positive for IGRA and TST, and HRCT showed a lymphadenopathy. But a word of caution that we should not be doing an ELISA TB because it's of very little diagnostic value, and especially because of a high prevalence of systemic tuberculosis in our part of the world. This patient was treated with ATT and oral steroids, and the vasculitis resolved. So another vasculitis, we see that this has got skip lesions. So this probably fits into something like a sarcoid. He had a raised ceramase and hyalurolymphadenopathy. He was treated with oral steroids, and the vasculitis resolved. So when would we order for serum ACE? So all cases of granulomatous uveitis, intermediate uveitis, and choroidal nodules. But a red flag here that patients on systemic steroids may have false negative values, and a normal ACE level does not exclude the disease. So in those cases, you may have to resort to a tissue diagnosis and probably do a lymph node biopsy and look for a non-caseating granuloma. Another vasculitis. Again, we would be thinking about TB sarcoid. Yes, but this is where the importance of a clinical examination lies, because as uveitis specialists, we are more physicians as compared to other ophthalmologists. So this patient had a mallow rash, and she had anti-dsDNA positive. Now we've come to choroiditis, a 66-year-old male with DV, and he had a choroidal nodule. Again, TB sarcoid, and at this age, we would think about metastasis as well. So again, we would do all tests for TB and sarcoidosis. So this patient had a raised serum ACE, a raised DSR, and a negative MAN2 and IGRA. So he was treated with oral steroids and he responded, and this is at the end of 3 months. A 34-year-old male, and he had a multifocal serpigenoid choroidopathy, which is thought to be of tuberculous origin now, so we must rule out tuberculosis for this patient. This has already been shown by Dr. Vijay. So just to wrap up, we have this patient. We know it's a non-granulomatous anterior uveitis. So to start with, you would be doing ANA HLA-B27. A granulomatous anterior uveitis, start with TB sarcoid. You have a retinitis like this. Think about infectious causes. This could be viral, ARN. So think of doing an AC tap and the immune status of the patient. This is a GHPC with active margins. This again, we would be thinking about tuberculosis as a first differential diagnosis and tailor our investigations accordingly. This was a 52-year-old man who was on steroids for chronic postoperative uveitis, no previous history of uveitis. So do you think we should be thinking about autoimmune causes first for him? Obviously not. We should be ruling out an infectious etiology. He underwent an AC tap and he tested positive for P. acnes. So the take-home message is the crux for uveitis diagnosis is a detailed history and a detailed examination. Come to a working clinical diagnosis, figure out your differentials, and do tailored laboratory investigations first. You would need extensive investigations only if there's a diagnostic dilemma or if the patient is not responding to your medication. I thank you for a patient hearing.
Thank you, sir, for your elaborate presentation and highlighting how we are going to order certain tests based on the certain phenotypes. So I will now like to invite Dr. Mayur for his presentation on basic imaging in uveitis, B-scan and UBM. These are case-based examples, case example-based talk.
मेरा ही है मेरा है वही है प्रेजेंटेशन ये निकालना ना वही है इसमें I would like to thank the organizers for having me here, and I start all my presentations with acknowledgements to my teachers at Sion Hospital and at LV Prasad Eye Institute and my teachers in counseling psychology. The session is on imaging in uveitis and my talk is on B-scan and UBM. It's a very basic talk and we are talking about 7 case scenarios. I'll be quickly going through all of them and we'll have a take-home message slide in the end. We are talking of the first case scenario, that is severe anterior segment inflammation. This is a 17-year-old adolescent with severe redness pain in the right eye, 5 days duration, and with a history of pain during urination for the past 1 day. You can see an organizing AC fibrinous exudate. The vision in the right eye was hand movement close to face, and there was no view of the fundus. The message here is that don't think this is only an anterior uveitis. It's better to ask for a B-scan. The B-scan in this patient showed few mobile vitreous echoes with marked thickening of the choroid at the posterior pole. There was no retinal detachment. On a little more inquiry, the patient was complaining of early morning lower back stiffness, and he himself confirmed that he had a urethral ulcer in the past and even now. He was tested for HLA-B27 where he was positive. He was treated with oral steroids, intensive topical steroids, cycloplegic agents, and immunomodulation with oral methotrexate. This is a case which highlights a more extensive involvement because of HLA-B27 more than the anterior uveitis that we all talk of. This is the second case scenario, that of necrotizing anterior scleritis. Now this is that of a 58-year-old lady. She had recurrent redness pain in the left eye, 6 months duration, was treated in the past 3 years back with tuberculous meningitis, a controlled hypertensive on treatment, a patient of hypothyroidism controlled with bilateral knee joint pain since the past 10 years. So we have bilateral knee joint pain, we have tuberculous meningitis, and we have the history of scleritis. This patient had a scleral necrosis. You can see the area of scleral necrosis here with the scleritis. This patient was investigated, turned out to be ANCA positive, strongly ANA positive, and strongly positive for thyroid antibodies. The Mantoux test was done, but it was obviously positive. She had suffered from tuberculosis in the past. The ESR was raised. Here we did a UBM. This was a UBM just to document the scleritis. You can see the marked diffuse thickening of the sclera and the area of thinning and associated thickening of the ciliary body. This is the same patient on oral methotrexate. This is the picture at 4 months of treatment showing the resolution of the scleritis. This is the area of scleral thinning. Although the eye is inactive, you can see the scleral thinning now. The disease was monitored then using ESR and ANCA levels. This is the third case scenario, that of tuberculous inflammatory iris nodule. This is the eye of a 52-year-old lady who had recurrent redness left eye, 5 months duration. You can see large granulomatous KPs in the Arl's triangle, but these are two areas where the iris appears elevated. So we requested for the UBM, and the UBM showed this picture, inflammatory iris nodule, which was extending into the ciliary body. We obviously suspected tuberculosis, requested for an ESR, which was raised. Her HRCT was normal, but a Mantoux test was strongly positive. This is a 2009 case when one would request for an HRCT. In current times, we would request for a contrast chest CT. Patient underwent AKT, total 9.5 months, after which she developed a complicated cataract. I would like to re-emphasize here that before doing the cataract surgery, it's best again to resort to USG-B scan and a UBM to look for cyclitic membranes. Patient underwent cataract surgery. The USG-B scan UBM was both normal, and this is a picture 2.5 months after cataract surgery. Vision of 6/9. This is the next patient to highlight a choroidal tuberculoma. This is a 26-year-old lady who had been on treatment of systemic pulmonary tuberculosis, came to us with a mild episcleral congestion of the left eye since the past few days. To highlight the importance of dilatation, on dilatation you see this, which is something like a scarred choroidal tubercle, but far there in the periphery you can see a huge choroidal granuloma. What we did was UBM over the choroidal granuloma to look for any scleral involvement. There was no scleral involvement, but on B scan we saw the dome-shaped choroidal elevation. Always when you request for the B scan, it is always good to request for the A scan vector. You can see the A scan vector over here. The patient has since been on treatment of systemic tuberculosis and is on our follow-up. The next case is that of posterior scleritis. This is a 12-year-old boy who had drooping of the left eyelid 1 year back, presented to us now with redness in the left eye. You can see the left eye redness. On fundus examination, a mild disc hyperemia with a pocket of subretinal fluid between the disc and the fovea, which prompted us to think of posterior scleritis, and hence we asked for a B scan. You can see the B scan, a mild disc hyperemia. The B scan shows the typical T sign of posterior scleritis, and on the OCT you can also see the little retinal elevation that's there because of the pocket of fluid. This patient was further had a dermatology workup because he had these lesions which were present on the axilla and the chest, and ultimately we came to a diagnosis of this syndrome which is called PAPASH, which includes pyogenic arthritis, pyoderma gangrenosum, acne, and suppurative hidradenitis. This patient has been treated with oral azathioprine and is been on treatment since then and is doing well. The role of B scan in the diagnosis of VKH disease cannot be overemphasized. Many times in VKH, you are going to have a very hazy view of the fundus and then may want to resort to B scan. This case is not so. Here we had a clear view of the fundus. A 41-year-old lady presented with sudden loss of vision, 4 days duration. no complaints suggesting of meningismus or tinnitus, a diabetic on treatment. This is the fundus picture on presentation, and the FFA showing the various stages. I've just put the late stage over here, the late phase showing the pulling of the dye. And herein the B scan is important because the B scan will typically show a peripapillary choroidal thickening and the elevated retina. These, you can see the pockets of retinal elevation are also obvious over here. The corresponding A scan vector. This patient was a case of ocular VKH treated with methylprednisolone, immunomodulated with cyclophosphamide pulses and oral azathioprine to achieve good vision. B scan findings in VKH disease have been highlighted. Patient will have choroidal thickening, retinal detachments and choroidal detachments. Almost 90 to 95% of the patients will have a choroidal thickening in VKH disease. Coming to the last case scenario, this is a pediatric panuveitis. Again, a highlight of the fact that HLA-B27 can cause a much more severe disease than one would think of. 13-year-old boy, known case of spondyloarthropathy, HLA-B27 affected in the left eye, treated with all possible agents before coming to us on prednisolone, sulfasalazine, methotrexate and infliximab. A very severe non-granulomatous anterior panuveitis, and we requested use of subcutaneous adalimumab. The patient still had multiple relapses, and you see this eye has now become hypotonous. We went back to the history to check whether the patient was compliant, and we found that the family had not been adhering to the treatment regimens. The entire family was counseled, and after sticking to the treatment regimen with the use of adalimumab injections, there were no further relapses. This is probably the most important message, the next message, as that is the eye had been quiet for about 3 months. The patient had a complicated cataract, and here it is always important that all of us anterior segment surgeons request for a B scan and a UBM. That's because we will come to know when to hand it over to the posterior segment surgeons. In this patient, the axial length by B scan was almost 18 millimeter. The radiologist felt that it was a pre-thusical eye. You can see the severely disorganized anterior segment on the UBM with cyclitic membranes. So when you have cyclitic membranes on UBM, a picture like this, always best that you involve the posterior segment surgeon first up. So we counseled the patient for a lensectomy, vitrectomy with a silicone oil injection. And this is the outcome, a very early outcome. This is almost 5 days post-op. The patient had has been since then on follow-up and has had affection of the other eye as well. So coming to the last, the take-home message, in severe anterior segment inflammation, always best to do a B scan to look for posterior segment involvement. Necrotizing anterior scleritis, one may use a UBM to document the scleral thinning, although it may be very obvious on clinical examination. Whenever you are seeing elevated iris nodules in a case of tuberculosis, it may be a good idea to do a UBM to look for the nodules on the iris. In choroidal tuberculomas, you can document them with B scan. In fact, B scan has got multiple features with which you can differentiate between various choroidal masses. Posterior scleritis, many times we have absolutely quiet eyes and patient complaining of severe retroorbital pain. It's a good thing to do a B scan, which is very non-invasive, and if you end up seeing the T sign, then you know you're dealing with posterior scleritis. VKH disease, looking for peripapillary choroidal thickening on a B scan can be important, especially if the view of the fundus is not very clear. And in cases of cataract with severe hypotony, always a B scan and a UBM to know when to hand it over to the VR surgeon. Thank you.
Thank you, Dr. Mayur, for your presentation highlighting the role of B scan and UBM in the patients of uveitis. Now I will request Dr. Risha KR for her presentation, Basic Imaging in Uveitis OCT.
First, let me thank the AIOC organizers and Dr. Bishwas for giving me this opportunity. I'll be talking about OCT, role of OCT in uveitis. Why it is important? As we all know, ancillary investigations are the backbone of uveitis workup. They help in making the diagnosis and ruling out certain differential diagnosis and also monitoring inflammation during follow-up. OCT is an optical biopsy of posterior segment structures with a high resolution, reproducibility and precision that correlates well with histology sessions. It helps in the localization of pathology by defining the extent, depth and thickness of the inflammatory lesion. So we will start from anterior and intermediate uveitis. Why to do an posterior segment OCT in an anterior and intermediate uveitis? To identify a CME. OCT helps in quantifying the macular edema, which has 89% sensitivity for the diagnosis of CME while comparing to FFA. Three distinct patterns of macular edema detected in uveitis. First is diffuse macular edema, then cystoid macular edema, then concomitant serous retinal detachment. The first picture shows diffuse macular edema with a serous retinal detachment seen in Behçet uveitis, and second picture shows a cystoid macular edema with a small serous retinal detachment in an intermediate uveitis, and third picture shows a persistent serous retinal detachment as well as few cystoid spaces along with ERM. This shows a typical cystoid macular edema which resolves well with the treatment. Another case of cystoid macular edema with the SFD started responding to a treatment. Quantitative analysis of macular thickness helps in monitoring the response to treatment, and these are the predictors of poor visual outcome in an OCT, like atrophy and disorganization of inner retinal layers and disruption of outer retinal layers. The presence of vitreomacular interface anomalies like ERM, VMA, VMT and macular hole indicate the cause of treatment failure. The first picture shows an ERM and second picture beautifully shows a vitreomacular traction. Now coming to posterior uveitis, occasionally posterior vitreous cells can be seen in an OCT as hyperreflective vitreous particles with or without CME. Now coming to a retinitis lesion, OCT shows hyperreflective thickening of the retinal layers with shadowing, and in this picture you can see posterior vitreous cells also shows an active retinitis lesion, and the same lesion responding with treatment showing thinning of the lesion and disappearance of the vitreous cells. Another Behçet uveitis with a retinitis patch shows a hyperreflective focal retinal thickening with shadowing beneath the lesion, and while resolution of the lesion shows a pseudofovea-like picture. Yet another case of TB choroiditis can very well see RP is elevated due to choroidal thickening, and there is a fluid detachment also. While treating with ATT, the choroidal thickness resolved and fluid detachment also. Now, it's a case of retinochoroiditis, which shows a full thickness hyperreflectivity and disruption of the retinal layers in the necrotic area with shadowing along with choroidal thickening beneath the lesion. The second picture, a typical choroidal granuloma characterized by hyporeflective thickening of the choroid with fluid detachment. It's a case of serpiginous choroiditis with an active and a scarred area. The active lesion shows again thickening of the focal choroid and hyperreflective deposits in the outer retina shows the yellow arrow shows the active part, and hypoautofluorescence scarred part characterized by loss of outer retinal layers and RPE, and the choroidal transmission is increased, so hyperreflective thinned choroid also seen underneath. This is a case of multifocal choroiditis. Again, active phase OCT shows RPE elevation by a homogeneous material and choroidal hyperreflectivity, and the quiescent stage OCT shows resolution of sub-RPE material. OCT also helps in identifying inflammatory CNVM, and it also determines the lesion activity to assess the response to treatment. Okay. Now OCT in white dot syndromes, spectral domain OCT shows photoreceptor layers and RPE disruption in OCT. And in exudative RD conditions like VKH and sympathetic ophthalmia, OCT is very useful in monitoring the serous retinal detachments. And the typical finding in VKH is SFD with subretinal septae. And EDI OCT also helps in monitoring the disease activity. So the take-home message is OCT is a very useful diagnostic modality for monitoring diagnosis and monitoring the inflammatory disease of the posterior segment. But don't forget about the history and clinical appearance. Thank you.
Thank you, Dr. Isha, for your presentation. Now I will like to invite Dr. Saurabh Luthra for his presentation on basic imaging in uveitis, fundus fluorescein angiography, ICGA, and autofluorescence. Sorry.
Good afternoon. I thank Professor Biswas and AIOC for this opportunity. So Dr. Risha has nicely set it up, and actually it's multimodal imaging which we normally use these days, and all the modalities you'll see can be combined very nicely to achieve a diagnosis. Thank you to the panelists as well. So I'll be just showing a few cases, and these are my acknowledgements. And we all know that FFA and ICG has certain differences. That fluorescein is mostly protein bound 80% and 20% is free, whereas ICGA is about 98% protein bound, only 2% free. That's why in the fluorescein it escapes the choriocapillaries and causes a lot of leakage, hiding the underlying details, whereas ICG does not escape, and that is why it is better for choroidal pathologies. And this flowchart is very nice. It's from a paper by Dr. Carl Herbert way back in 2009, and it kind of nicely summarizes how fluorescein and ICG can be used for diagnosis. So I'll just show a few quick cases. This is a case of peripheral retinal vasculitis in a 59-year-old male with floaters for the past 4 months in the left eye. Disc was within normal limits. There was a fine ERM with multiple peripheral NVEs with few perivascular CRA patches, and left eye also had an old vitreous hemorrhage. So this is how the the FFA picture looked. and you can see the changes in the peripheral retina, the staining of the vessels and CNP areas. HRCT thorax, there was no active lung lesion, pleural thickening and calcification was present. The MAN2 was 25 millimeters. ACE was normal, VDRL was non-reactive. Both eyes underwent PRP laser and under oral and topical steroids and ATT cover. So this is how it looked like at presentation. This is another case of peripheral retinal vasculitis, again presenting with floaters for the past 1 week. Vision was 6.6 OU, and there was NVD in the right eye with vitreous hemorrhage, and both eyes had NVEs, RPR. So this is what the picture of the FFA looked like. You can see gross capillary non-perfusion in the periphery here, almost wiped out, capillary bed in the periphery. There is some perivascular staining, and this in the right eye is block fluorescence due to vitreous hemorrhage. The serum RPR was non-reactive, ACE was 15, CBC was within normal limit, X-ray chest was normal. Patient underwent again PRP laser to avascular retina under topical and oral steroid cover. In this case, we didn't give ATT because there was nothing to kind of point towards that. So again, this is the picture of the other eye of the angiogram, which showing extensive capillary non-perfusion areas. We can have syphilitic multifocal choroiditis. This is a young male, VDRL, TPHA positive, and a tongue chancre history he gave. And vision was 6.18 in the right eye, left 6.9, improving to 6.6. And there were vitreous cells in both eyes. And this is what we saw on the fundus photograph, where you can see, light chorioretinitis patches and with some hemorrhages. And there's a disc edema in the right eye. VDRL was reactive, TPHA was positive, ACE was normal, chest X-ray was normal, MAN2 was negative, ANA was positive, and HIV was negative. And this is the OCT, and OCT has nicely been covered by Dr. Risha, and you can see the hyperautofluorescent areas more in the right eye showing active choroiditis. And this is what the FFA ICG looks like, and you can see hypo with hyperfluorescence and lot of hypocyanescence also in both eyes, corresponding to the areas of activity. There was no neurological sign symptoms, and treated with oral and topical steroids and 3 doses of intramuscular benzathine penicillin for 3 weeks. Post-treatment, this is what the fundus picture looked like. BKH has already been shown on the OCT. Basically, patient has a lot of inflammation, and there are multiple choroidal granulomas with disc hyperemia, and there is early pinpoint hyperfluorescence, as you shall see soon. In the OCT, you can have these folds or undulations at the level of the choroid and retina with subretinal fluid. And obviously, there is disc edema as well, which is again a hallmark of VKH, acute VKH. And you can have early pinpoint hyperfluorescence and late pooling of the dye here, you can see on the angiogram. Again, you can see early pinpoint hyperfluorescence and late pooling of the dye in the late phases. So in this case, there was bilateral pleural thickening, and CBC, ESR was normal, ACE was normal, VDRL was non-reactive, and patient was given oral and topical steroid and then put on immunosuppressants in the form of azathioprine, which the patient took for the next 6 to 8 months. And patient continued to be fine. Azure is another condition in 30-year-old males presenting with scotoma in the right eye for 1 week, left eye 2 months, best corrected vision was 6.6. Diagnosed elsewhere as glaucoma or query CSR, and white dot syndrome also was made, this diagnosis. And you can see here on a cursory examination, on a fundus examination, you can easily miss this condition. The fundus is fairly normal looking, but on autofluorescence, it's quite remarkable. You can see these hypo-autofluorescent background and these hyper-autofluorescent speckled patches, especially in the juxtapapillary area and also nasal to it. In the left eye, it is a kind of established azure, whereas in the right eye, it's acute. That is why you can see that the right eye vision is, the scotoma is more dense in the right eye. And this is what you see on FFA ICG. You can see actually a tri-zone. Three zones are there in which there is a hypo and a hyper and then again a hypo. In the juxtapapillary area and also nasal to the disc, and on the ICG you get a very clear-cut area of hypocyanescence, which is quite remarkable. And that a similar picture in the left, but it was more chronic, so in the right eye it is more an acute presentation. And this is 3 months post-treatment, vision OU became 6.6. And so this is how you picked it up on the fields. You can see in the top left that there was a dense scotoma involving the fixation and the blind spot, more so in the right eye. Left eye is a healing or a resolving azure, so you can see scotomas are not that dense, but with follow-up, these scotomas, they resolved. Choroidal granuloma has already been shown on the OCT. This is a 43-year-old woman, right eye black spot, and history of 1 month being treated with oral corticosteroids and first line 4-drug ADT, 66 OU, and fundus showed a choroidal granuloma in the right eye. Mantle was 30 by 30. Positive IGRA and HRCT chest was normal, and PET CT showed some lymph nodes. And this is a very old patient actually, so I'm sorry for the poor quality of the angiogram, but you can see here that this is actually a very important telltale sign on fundus photography, which Professor Amod Gupta has taught us, that there is a chorioretinal anastomosis and you can have a hemorrhage overlying this granuloma. So this is a telltale sign that this is a TB granuloma. And you can see initial speckled hyperfluorescence and later on lot of intense hyperfluorescence in the area of the granuloma. Mantle was 30 by 30. HRCT chest was normal, but quantiferon TB gold was positive. Patient was put on ATT and systemic steroids, then followed up at PGI, treated there with ATT, systemic steroid, and intravitreal Avastin several times for SRF involving the macula, and then followed up for several years. Actually, this patient is still on follow-up there and received multiple intravitreal bevacizumab injections. And every time the activity comes back, it is treated with bevacizumab very nicely. And in fact, Manisha Agarwal has done from Shroff Charitable in Delhi has done a lot of work on the VEGF levels in these cases and has shown experimentally that the VEGF levels are several thousand-fold high. And these patients benefit by IV anti-VEGF, intravitreal anti-VEGF agents. This is the follow-up of the same patient. Eales disease, this was a very interesting case. 27-year-old male, bilateral aggressive eales, left more than right, treated over 5 years with systemic steroid, first line, 1 year of second line ATT, and 5 sittings of PRP laser, and underwent left eye VR surgery for this prolif that you can see here. This is the initial presentation, and then he went on to develop a prolif and was operated, and you can see the amount of neovascularization and capillary non-perfusion, and it needed oil in the left eye, and quantiferon TB was gold was positive, and the rest of the workup was mostly negative. This surgery was done at Shankar Netralaya, Chennai, and Dr. Biswas has also been treating this case. And patient remains stable, is still on follow-up, and is maintaining vision. And in the left eye needed even glaucoma filtering surgery. Bilateral recurrent serpiginoid choroiditis, you can see here that in bilaterally the peripapillary area, you can see a hyperfluorescence on the angiogram corresponding to the creamy lesions seen on fundus photograph. And Manto in this case was positive. Chest X-ray showed infective foci. RPR and ACE were normal. HRCT chest showed apical fibrotic lesions, mediastinal lymph nodes, pleural thickening. Patient was put on ATT. This is what the ICG looks like. You can see hypocyanescence in the area of hyperfluorescence, which we saw in the area of serpiginoid lesions. And after 3 doses of IVMP under ATT, this is what the patient looks like. And after tapering doses of steroids, the OCT flattened out and developed a CNVM later on, choroidal neovascular membrane, which, this is autofluorescent. There's no angiogram at this time because mostly we were following CNVMs can nicely be followed on OCTA. So nowadays we use it because it's a non-invasive modality. Both eyes received ranibizumab and is stable now on systemic methotrexate and topical AGMs. Posterior scleritis, 49-year-old female, metamorphopsia since 1 month, right eye disc and macula normal, left eye minimal disc blurring and resolved SRF. OCT was normal in the right eye, and left eye had a bacillary layer detachment to start with, but then resolved over time. There was no CNVM, so this is what the patient presents with. You can see here that it's a kind of a mound, and there is some SRF with the bacillary layer detachment in the left eye. On the ultrasound, you can see an exudative component of the retinal elevation. And these are the FFA and ICG at presentation. You can see a little bit of hyperfluorescence in the late phases in the left eye, and also hypersenescence on ICG. Patient was treated with topical steroids and Indocap SR, and 8 months follow-up, flattened out, and the area resolved. Sarcoid can present with, so this is a patient with sarcoidosis, 69-year-old, OU redness pain, cells flare, mutton fat KPs, snowballs, areas of chorioretinal inflammation. This is what the angiography looks like. You can see a lot of leakage at the disc and in the retina, and also staining of the vessels. This is what the left eye looked like on angiogram. OCT was okay, and patient was treated with oral and topical steroid and azathioprine, and has been on follow for the past almost 12 years, is on remission on azathioprine. Behçet's disease, 9-year-old male with painless diminution of vision, both eyes, 6/18 and 6/6. Right eye had vitritis, disc edema, snowballs. Left eye had vitreous cells. HLA-B27 negative. IGRA nil. MANTO was normal. ACE levels were okay. And this is what the angiogram looks like. You can see here, a little bit of a ferning pattern that you can see in the right eye, which is quite classical. I'll be finishing shortly. And diagnosed as Behçet's after an HLA-B51 positive, treated with IV solumedrol, and then followed by omnacotil and folitrax. And this is how it resolved. This is B-dump, diffuse uveal melanocytic proliferation in a 58-year-old male. DV right eye 2 weeks, left eye 3 months, diagnosed elsewhere as CSR, had a history of renal carcinoma for which he undergone radical nephrectomy, and you can see here a starry sky appearance in the right and left eye, and with a speckled hyperfluorescence. And this is a swept source OCT, and you can see here subretinal fluid with undulations at the level of the deposits at the level of the RPE. This is the very giraffe pattern of autofluorescence which you see very classically in B-dump, also called leopard spot pigmentation. And patient was treated on oral chemotherapy and further refused to undergo plasmapheresis or radiation therapy, and finally became neovascular glaucoma with a closed funnel RD and lost vision in both eyes. T-cell PVRL, a 57-year-old female, presented to us with vision of 6/18, right eye low-grade vitritis, left eye dense cataract. Systemic investigations were largely non-contributory. Also presented with optic neuritis. Uveitis panel was non-contributory. Vision was, when she presented later, vision was counting finger close to face in the right eye, 6/18 in the left. This is what the fundus picture looked like. You can see some glaucomatous changes in the disc. In the left eye, gross RP alterations at the posterior pole. And this is what the OCT looked like. So there are these, some deposits again, subretinal deposits in the right eye. In the left eye, there's a sheet-like, between the RPE and the Brooks, there is a sheet-like deposit. And this is a leopard spot appearance on autofluorescence in the left eye, very marked. And this is the angiogram again showing a leopard spot, changes of hyperfluorescence. And underwent, a diagnostic vitrectomy which was positive for CD3/4 but negative for CD19/20, and was diagnosed as a T-cell lymphoma and treated with 25 injections of intravitreal methotrexate and stabilized on that, and this is the final follow-up of that. I think I might, am I running out of time? Yeah, okay, so I will just go on to see if there's anything. So toxoplasma has already been shown, OCT has been shown. I'll just end with these cases, the final few cases. These are some cases which we saw, and you can see here that on FFA you can see a speckled hyperfluorescence corresponding to the juxtafoveal lesion, and on OCT you can see the flattening out with treatment. Again, retinochoroiditis primarily involving the inner retina, later on resolving on OCT, and the angio basically shows hyperfluorescence which becomes intense later and gradually settles with treatment. And I think I'm out of time. I wish I could have, but thank you so much. Yeah.
Thank you, sir, for your presentation. So now I will like to invite Dr. Padma Malini ma'am for her presentation, Recent Advances in Imaging in Uveitis.
Thank you. Thank you so much. Yeah, sure.
Very good afternoon to all of you. At the outset, I'd like to thank Uveitis Society of India and AIOC team for giving us opportunity to have the subspecialty session for Uvea. And I'll be talking to you all on recent advances in ocular imaging in uveitis. Ocular imaging can be done from pole to pole, imaging the keratic precipitates to imaging the cones in the posterior pole using adaptive optics. what are the imaging methods are available? So slides are not coming. Yes. So we image the keratic precipitates to the cones. Keratic precipitates by confocal microscopy, the cones with the help of adaptive optics. Let us see the list of what are the advances are available in various imaging methods. In the corneal imaging, in addition to the confocal microscopy, anterior segment OCT is there. Iris can be imaged with anterior segment iris angiography. Now we have, in addition to the sun grading, we can quantify the amount of cells present in the anterior chamber using anterior chamber OCT. The vitreous haze can be quantified by the OCT, and also we have various imaging methods for the grading. In the retinal imaging, we have multicolor imaging and also ultra wide field imaging, FFA, ICG, ACTA. Recently, we have fluorescence lifetime imaging ophthalmoscopy, where we can do the modification in the autofluorescence imaging. Coming to the choroid, enhanced depth imaging has been used to study the choroid in depth. In addition to that, we have various methods which has been highlighted by my previous speakers. In addition to that, we also have laser Doppler holography, where we can exclusively study the hallux and satellus layer in the choroid. And adaptive optics can be used to study the optic disc, the retinal vessel changes, and the quantification of cones. In vivo confocal microscopy is a non-invasive technique that demonstrates the anatomical tissues at the tissue level. We all know we have different patterns of non-infective and infective patterns. This already have been described. The globular, multiglobular, and stippled are a non-infective pattern, whereas dendritic and infiltrative, central globular and dendritic suggestive of infective patterns. Recently, we have described the confocal microscopic appearance in a case of acute lymphoblastic leukemia, where you have hyperreflective central dots. The cells are smaller compared to the endothelial cells. These are morphologically similar to the acute lymphoblastic leukemic cells on AC aspirate cell. Next is confocal microscopy. Lymphoma, we have various imaging biomarkers. In addition to OCT, confocal microscopy can be used to diagnose. Here we have complete or incomplete floral pattern which are present in intraocular lymphoma, which we recently published in Ocular Immunology and Inflammation. Recently, Lim et al. Have reported a ink blot type of keratic precipitates in viral uveitis. This is a new, has been added in the literature compared to the existing one. Recently, we published, we had a case, patient who went to South America and came back. He had a uveitis, diagnosed of ocular histoplasmosis. This is a confocal microscopy showing the histoplasma cyst, and patient responded well to treatment. The next comes, we'll move on to anterior segment optical coherence tomography. We can use to study the hyperreflective dots in the anterior chamber, where you can quantify the amount of the cells and also the amount of cells present in the posterior curvature of the cornea. We can calculate the aqueous to air relative intensity, ARI index, which help us to quantify the AC anterior chamber flare. AIOC2022 also, they have described various types of keratic precipitates. Here, diffuse fine are seen in herpes simplex infection, whereas quadrilateral and ellipsoid pattern are seen in varicella zoster virus infection. Coin-shaped keratic precipitates are seen in CMV endothelitis. These are the various AIOC2022 features of keratic precipitates which has been described in the literature. Based on the reflectivity, high reflectivity keratic precipitates are seen in varicella zoster virus, CMV, and also in intraocular lymphoma cases, whereas HSV shows low reflectivity. Using the anterior segment OCT, we can quantify the amount of cells present in the anterior chamber 0 to 4. This has been published in the literature. Next, we'll move on to anterior segment angiography. Using this, we can study the iris vasculature. We can map out the areas of iris ischemia. Next, we'll move on to posterior segment. In the posterior segment, what are all the methods are available for imaging? In the posterior pole, defined when we can view the 50 or 55 degrees of the fundus. The mid-periphery, we call it as from the retina extending from the vascular arcades to the vortex vein ampulla, that includes 60 to 100 degrees. Far field or the ultraviolet field, which has come up in a big way in the diagnosis and management of uveitis, where we can anterior edge of the vortex ampulla to beyond to pars plana. 110 to 220 degrees it covers, the pan-retinal up to 360 degree. What we commonly use is an optos, which covers up to 200 degrees of the fundus. The next comes the iris autofluorescence. In addition to the posterior segment, autofluorescence imaging can be used to study the iris changes. Here you can see the hypoautofluorescence in a case of a sarcoid granuloma. Here is a case of a Fuchs uveitic syndrome showing depigmented iris, where you can see the petaloid pattern, and whereas the other atrophic changes are better appreciated in iris autofluorescence imaging. Ultraviolet field imaging, we have red only or red-free imaging. These imaging techniques are used to quantify the amount of vitreous inflammation in uveitic cases. Here is a case of a 12-year-old child who have intermediate uveitis. On evaluation, the patient had increased proteinuria, diagnosed have a SLE. SLE presenting with intermediate uveitis is a rare entity. This child responded well to systemic cyclosporine and systemic steroid therapy. We could see the resolving pars plana exudates in this case. The following FFA, there was a capillary non-perfusion areas are treated with laser photocoagulation, where you can see the laser marks in this case. Here is a case of a Behçet's disease showing fern pattern of leakage using ultraviolet field imaging. Ultraviolet field angiography, ICG, is used to study the retina, and also you can see the vortex vein and other choroidal changes. Here is a case of a dual angiogram where you have FFA and ICG. In ICG, we could see multiple hypofluorescent dark dots. They are more extensively involved in ICG compared to the fluorescent angiography in a case of a VKH disease. Here we use not only for diagnosis but also monitoring the response to treatment. Ultraviolet field optical coherence tomography and angiography can be used. This is basically they use a stitch technique to study the far periphery. Now we will see the case examples. Enhanced depth imaging is used to study the posterior uveitis. Here, by using the EDI technique, in addition to measuring the choroidal thickness, we can also study the morphological changes. In Sattler's layer is predominantly involved in case of sarcoidosis. Here, how do we differentiate? Here you could see the reflectivity. This is seen in case of granuloma, whereas those reflectivities are absent in a case of a choroidal vessels. Based on this, we can differentiate the choroidal granuloma from choroidal vessels. And also during the healing pattern, the antero-posterior dimension of the granuloma is decreased compared to the lateral extension, which has been described by Anirudh et al. From a PGI group. Next, based on the morphology, we can differentiate the TB from sarcoid. In TB, the granulomas are, you can see the heterogeneous lobulated granuloma, whereas in sarcoid, they are homogeneous granuloma. Next comes the choroidal vascularity index. The proportion of the vascular area in the choroid can be computed by a special algorithm, can provide us the vascularity index of the choroid. We have worked on Rupesh Agarwal team in a case of a VKH where we have calculated the choroidal vascularity index. This could be used as an additional tool monitoring the disease course, where we could see here, this is the choroidal thickness, this is the choroidal vascularity index. At presentation and following treatment, we could see not only the choroidal thickness is decreased, but also the choroidal vascularity index is decreased in these cases. Next, we'll move on to multicolor imaging. In multicolor imaging, we have blue, green, and infrared reflectance. Depending upon the site of the involvement, the changes are better appreciated using, especially outer retinal changes are better appreciated in infrared imaging. Recently, we published an article of multicolor imaging in post-fever retinitis cases, where the different wavelengths can be helpful in find out the different activity. Here, you could see the whitish lesions mainly seen in the blue and green reflectance images, the dull gray or grayish during the resolving stages, and dull green is seen in resolved cases of post-fever retinitis. Optical coherence tomography and angiography can be used to study the vascular changes in the choroid that have been extensively used in case of serpiginous choroiditis. A most important utility is in studying the choroidal neovascular membrane. We have done the qualitative and quantitative analysis in post-fever retinitis cases, and we found that the deep capillary plexus has more capillary rarefaction when compared to superficial capillary plexus. The foveal avascular zone were altered and is irregular network. So, ACTA is not useful in case of gross macular edema or active retinitis cases. Whenever we see an altered FAZ, could be an indicator of macular ischemia. Wide field optical coherence tomography based microangiography is a recent addition. Here we could see the angiographic changes present in the nerve fiber layer of the peripapillary retina. The choroidal vasculature can also be imaged by using laser Doppler holography. In this, we can separately study the Sattler's and Haller's layer, which has been used in retinal diseases. Coming to the adaptive optics is a non-invasive imaging method.
We are running late.
I'll conclude.
Please.
I'm just finishing with this.
Okay. No
We
problem.
can study the cone, optic disc, blood vessels, and RPE. Here is a case of a granulomatous polyangiitis. The fundus looks normal. FFA shows staining of the vessels. You can see the parallel sheathing and adaptive optics. Following treatment, we could see the resolution of the sheathing in this case. To conclude, multimodal imaging can help not only in making the correct diagnosis and also in documenting and following up the patients after therapy in inflammatory conditions of the eye. Thank you for your attention. I really appreciate, this talk was before the lunch. I'm standing before the lunch. Thank you.
Thank you, ma'am, for your presentation. So as we are running late, I would like to thank all the speakers for this session, my co-moderators, and the chairs for the session. And now I will like to invite the moderators for the next session to take over, please. Thank you.